This is how it looks like. All these cases are cases of your conjunctival xerosis. So third is your X1B, which is Bitot spots. So it is an extension of the xerotic process seen in stage X1A. So Bitot spot is a raised, silvery, white, foamy triangular patch of keratinized epithelium situated on the bulbar conjunctiva in the interpalpebral area. As you can see in this image, this is foamy, white, silvery and raised. You can see in this image also, these bubble-like areas. These are foamy, raised and silvery in appearance. These occur on your conjunctiva and in the interpalpebral area. And it is usually bilateral and temporal and less frequently nasal. Then coming to X2, which is corneal xerosis. So after conjunctival xerosis, there is corneal xerosis. So the earliest change in cornea is the punctate keratopathy. So this is how a punctate keratopathy looks like. These dotted raised erosion-like areas. These can be stained when you stain the cornea with fluorescein. Okay, these whitish dot-like areas. This is punctate keratopathy. It begins in the lower nasal quadrant and followed by haziness and granular pebbly dryness. There will be raised punctate erosion areas in the cornea. Then there will be lustreless hazy cornea also. And this is how a lustreless dry cornea looks like. Now coming to X3A and X3B. So X3A and X3B is corneal ulceration or keratomalacia. So a stromal defect occurs in the late stage due to colliquative necrosis and it takes several forms. So because of the dryness, there is chances of necrosis in the cornea. So this necrosis leads to small ulcers and large ulcers. So small ulcers have size of 1 to 3 mm and these are peripheral, circular, with steep margins and they are sharply demarcated. This is how a small ulcer looks like, 1 to 3 mm in size. Then we have large ulcers also. So the area of necrosis may extend centrally and it can involve the entire cornea. And the stromal defect in this, if the stromal defect is involving less than 1/3 of the cornea, so it will heal and there will be some vision. But if the stromal defects are more than 1/3 or it is X3B, then that can lead to blindness if it doesn't heal. There will be perforation and then eye can go into phthisis also. So this is how a perforated ulcer looks like. What do you call this picture? Can you identify? Corneal perforation with the iris coming out. What is it called?
Atrophic bulbi.
Prolapse of iris.
Prolapse of iris. And when it epithelialized, then it is called anterior staphyloma. Okay. So if an ulcer is more than 1/3 of the extent, then this can happen. And if this heals slowly, either we will have to eviscerate the eye or the eye can go into phthisis. And this is how a phthysical eye in a child looks like. Both of the eyes are phthysical. So this child becomes blind due to vitamin A deficiency. Then XS is corneal scars. So if the ulcer heals, it will leave a scar. So healing of stromal defects results in corneal scars of different densities and size, and which may or may not cover the pupillary area. If it covers the pupillary area, there will be loss of vision, and if there are small peripheral scars, then it will be dead. This is how a corneal scar with vascularization looks like, and this is how a corneal scar bilaterally looks like. Then XFC. This is xerophthalmic fundus. This is how a xerophthalmic fundus looks like. It is characterized by typical seed-like raised whitish lesions which are scattered all over the fundus and at the level of optic disc. This is how a xerophthalmic fundus looks like: whitish, small, discrete seed-like lesions scattered all over the fundus. So coming to the diagnosis, first is your clinical diagnosis, which can be done on the basis of signs and symptoms. Then how we will confirm the diagnosis? By doing serum retinol levels. So the normal levels are 1 to 3 micromoles per liter or 28 to 86 milligram per deciliter, and vitamin A deficiency is less than 10 mg per dl. Now coming to the treatment and prophylaxis. So for ocular therapy, local ocular therapy, if the patient is only having conjunctival xerosis, we can start with artificial tears, 3 to 4 hours. And if there is keratomalacia or there is corneal ulceration, we will start treatment according to the treatment of bacterial corneal ulcer. Now coming to the vitamin A therapy. It can be applied to all stages of xerophthalmia. So we have two ways of doing the therapy. First is oral administration, which is according to the WHO recommended schedule, and the other is your intramuscular injections. And if the patient is having lots of vomiting and severe diarrhea, in cases where oral administration cannot be done, we give intramuscular injections of water miscible preparations of vitamin A. So this is the WHO recommended schedule. So above the age of 1 year, we give 2 lakh international units orally or 1 lakh international unit IM as injections on diagnosis if a child is diagnosed with vitamin A deficiency. So after giving this first dose, we will repeat the dose the next day, and then we will give a third dose 4 weeks later. And if a child is having age less than 1 year, and if child is having a weight less than 8 kgs, and he can or she can be of any age, but if the weight is less than 8 kgs, then we will give 1 lakh international unit orally and 50,000 international unit IM. In women of reproductive age group, who are pregnant or not, and those having night blindness, conjunctival xerosis, and Bitot spots, they are treated with a daily dose of 10,000 international unit orally for 2 weeks. And for corneal xerophthalmia, we will give a full dosage as per above the age of 1 year. That is 2 lakh international units are to be given. So this is your WHO recommended schedule. So coming to the prophylactic treatment. So we have 3 approaches. First is your short-term approach, then medium-term approach, and then long-term approach. So in short-term approach, if an infant is 6 to 12 months old and any older children who weigh less than 8 kgs, he is to be given 1 lakh IU orally every 3 to 6 months. In children 1 to 6 years of age, 2 lakh international unit are to be given orally every 6 months. In lactating mothers, 20,000 IU orally once at delivery or during the next 2 months. This increases the concentration of vitamin A in the breast milk and help to protect the breastfed infant. Then if the infant is 6 months old, less than 6 months old, and not being breastfed, then we will have to give 50,000 IU orally before the age of 6 months. So this is the revised schedule of vitamin A supplements being given. This is followed in India since 1992 under this program of Child Survival and Safe Motherhood. So in this, the first dose is given of 1 lakh IU at 9 months of age along with measles vaccine. Then second dose is given of 2 lakh IU at 18 months of age along with the booster dose of DPT or OPV. Then third dose of 2 lakh IU is given at the age of 2 years. This is also in your immunization schedule. Then we have a medium term approach. In this, we will have to do a food fortification with vitamin A to prevent the deficiency. Then in long term approach, this should be your ultimate aim to prevent the vitamin A deficiency. In this, we will have to take an adequate intake of vitamin A rich foods such as green leafy vegetables, papaya and drumsticks, and nutritional health education should be included in the curriculum of school children. So now coming to your autoimmune disorders. So how your autoimmune disorders, they present in your eyes. So first is your rheumatoid arthritis. Everyone knows rheumatoid arthritis. So in rheumatoid arthritis, we have dryness of eye, that is keratoconjunctivitis sicca. Then there can be ulceration in the cornea, which can manifest as ulcerative keratitis. Then there can be acquired superior oblique tendon sheath syndrome, and there can be scleritis. So this is how scleritis looks like. The sclera becomes thin and the uvea protrudes out. And rheumatoid arthritis, you know all that there is swelling in the joints, small joints. And this is how a dry eye looks like, red and dry. Next is your systemic lupus erythematosus. So in this also we have dry eye, keratoconjunctivitis sicca, scleritis and optic neuropathy. So there is optic neuropathy, then we can also have peripheral ulcerative keratitis in this, and retinal vasculitis can also be there. There will be sheathing of the retinal vessels. Then next is sarcoidosis. So in sarcoidosis we have 30% of the ocular signs. So in this we will have phlebitis. Phlebitis is the sheathing that develops around your vessels. Then we can have iris nodules, these brownish nodules. These are your iris nodules. Then we have mutton fat capies also. So there will be, which type of uveitis has mutton fat capies? Granulomatous. Then in Sjogren syndrome. So Sjogren syndrome had two components, dry eye and dry mouth. So we will have dry mouth, along with there will be dry fissured tongue, there can be dental caries and parotid enlargement. And in Sjogren syndrome, the dryness is so much that whole of the eye develops keratinization also. Then coming to ankylosing spondylitis. So in ankylosing spondylitis, acute anterior uveitis and scleritis is the most common symptom. Patients sometimes present with uveitis also. And when you go for the systemic your diagnosis, then you find out that the patient is having rheumatoid or ankylosing spondylitis. So what test do we do for ankylosing spondylitis? HLA-B27. So what symptoms do we find in ankylosing spondylitis? There will be photophobia, there will be redness and decreased vision. Now Retter's syndrome. So Retter's syndrome has a triad of urethritis, conjunctivitis and arthritis. And if all these things are present, then we can diagnose the patient with Retter's syndrome. So in eye, we have lots of signs in Retter's syndrome. We have conjunctivitis, we can have acute anterior uveitis, nummular keratitis, episcleritis, scleritis. Papillitis is, what is papillitis? Inflammation of the optic nerve. Then retinal vasculitis also. That is inflammation in the retinal vessels or retinal vessels disease. Now coming to the Behçet syndrome. So in Behçet's disease we have hypopyon uveitis. There will be redness, pain, diminution of vision, and all this is because of uveitis. So you can see a hypopyon here. Then we have inflammatory bowel diseases. So we have two types of inflammatory bowel diseases. One is your ulcerative colitis and the other is your Crohn's disease. So in this we have lots of ophthalmic manifestations like acute anterior uveitis. There will be peripheral corneal infiltrates. These are the corneal infiltrates along your limbus. Then there can be conjunctivitis, episcleritis, scleritis, papillitis and retinal vasculitis. So your uveitis is the most common finding that you find in your autoimmune diseases. Then coming to your giant cell arteritis. So giant cell arteritis, it affects your superior temporal artery, ophthalmic artery, your posterior ciliary and proximal vertebral artery. So if a person is having a giant cell arteritis, you can see all these vessels engorged and these vessels can be seen. Superficial temporal arteries, they become raised and engorged. So it presents as AION and cilio-retinal occlusion. There can be central retinal artery occlusion and we can also see cotton wool spots in the retina. AION is, what is AION? Anterior ischemic optic neuropathy. Then coming to the vasculitis. So these are the following diseases that comes under vasculitis. These are vaginous granulomatosis, polyarteritis nodosa and relapsic polychondritis. So all these diseases, they present in eye as necrotizing scleritis. Then there can be peripheral ulceration in the cornea. Then we can have occlusive retinal periarteritis. The cryocystitis can be there. Then scleritis and uveitis. This picture shows your dacryocystitis. Your lacrimal gland is inflamed. Then coming to your hematological diseases. So in hematological diseases we have anemia, leukemia, lymphomas and sickle cell anemia. So in all these diseases we will see the fundus for the finding. And in fundus we have a typical presentation, that is rod spot. So there will be lots of hemorrhages and along the hemorrhages we will see these large hemorrhages which have a whitish center. So these are your rod spots. Then these are typical of your hematological diseases. And if you find a fundus with optic disc, your optic disc is raised or this swelling along with a rod spot, you can ask the patient for all investigation for all these diseases, for anemia, leukemia, lymphomas. So this is your rod spot. Hemorrhage with a whitish center. Then in sickle cell disease, we see a C-fan neovascularization. The neovascularization will be in the form of a fan along with this fibrosis. This is how we see this is the finding we see in sickle cell disease. C-fan neovascularization. Then coming to the infectious diseases. How the infectious diseases they present in your eye. So first is tuberculosis. So tuberculosis is one disease that affects all the parts of your eye except for your lens. So in uvea, there will be chronic granulomatous anterior uveitis and there will be multifocal choroiditis. So we will see lots of mutton fat gippies in tuberculosis. Then in eyelid, we can see nodules. Those are known as lupus vulgaris. Then in orbit, we can see cellulitis, dacryoadenitis, dacryocystitis and abscess also. Then in conjunctiva, we see flicked annular conjunctivitis. What is flicked annular conjunctivitis?
Allergic flicked.
So flicked annular conjunctivitis is this, the second picture. This is a raised nodule near the limbus and there is ulceration present over the nodule. So if we stain it, the nodule will take up the stain. So does the nodule of scleritis and episcleritis, does it take up any stain? No, that is how you differentiate it your nodules of episcleritis and scleritis. Because only this nodule takes up the fluorescein stain. Then in cornea we have rectangular keratoconjunctivitis and interstitial keratitis. In sclera we will have scleritis, episcleritis and nodular scleritis. And in retina we will have exudative retinitis and vascularitis. And in optic nerve there can be papilledema and optic neuritis. So it affects all the parts of your eye except for your lens. Then coming to leprosy. So in leprosy we can see facial palsy, mydrosis. What is mydrosis?
Loss of
Loss of your
eyelid.
eyelashes and eyebrows. Then granulomatous iritis can be there. We can have episcleritis or scleritis. There can be secondary glaucoma and cataract. Then in syphilis, we have three types: congenital, secondary and tertiary. So in this also we will have if a neonate is to be suspected with syphilis, and we will have to do a fundus examination. So there is a typical fundus picture that is known as salt and pepper fundus. That is what you look for. Then there can be iritis, choroiditis. There can be exudates around the disc. Then there can be chorioretinitis or vascular sheathing. Then coming to the viral diseases. So these are the viral infections that present in your eye also. You all know about herpes zoster, herpes simplex, CMV, rubella, measles and AIDS. So AIDS also presents in your eye. So this is how AIDS presents. So in eye we can have the most common tumor that is known as Kaposi's sarcoma. Then we can have AIDS retinopathy. We will see these whitish lesions in the retina, which is 50 to 70% they are present. Don't talk. Then we can have anterior uveitis, and this is how your retina looks like when a person is having AIDS. There will be optic atrophy, and there can be these exudates, whitish exudates in the retina. So this is known as CMV retinitis. Then if a person is